Good morning. Welcome. Thank you for all sticking with us through Saturday. I have this affinity for finding myself standing up here on Saturdays lately. And many people, such as yourselves, have always stuck it through to join us. I'm Joanne Kalina, and I'm the program coordinator and advanced practice nurse at Northwestern Medicine in Chicago.
Hi, and I'm Jen Burke. I'm the nurse practitioner for the PEDS program at Rush University Children's Hospital in Chicago.
And today we'd like to talk about some symptoms in CF. So let's get to the bottom of it. Our objectives are to summarize the signs and symptoms of CF-related GI symptoms such as DOS, constipation, along with the medications that we use to treat, to demonstrate an understanding of delayed gastric emptying, treatment and evaluation, and to differentiate between GERD and GRASP.
Our presenters today are Dr. Adam Stein, who will be talking about constipation versus DOS. Dr. Shipla Sood, gastric emptying. Dr. Megan Gable, SIBO, and Dr. Jeffrey King, who will be speaking about GERD versus GRASP.
And with that, we will get started with Dr. Stein. Adam Stein is a Digest graduate. He's currently the CF gastrointestinal gastro doctor for the adult program at Northwestern. And now if I can find the magic button that I just hit the last time. Thank you. Is the microphone working better? This one?
Good for you.
Well, they had a problem last session. I just wanted to make sure.
Want it louder?
No, I think we're okay.
All right, thank you. I'd like to thank Joanne and Jen for inviting me to give this talk. Can you all hear me? Anybody can't hear me, just yell. My name's Adam, I'm from Northwestern, and I am a proud graduate of the Digest program, the second cycle, or 2.0. And we're gonna talk about constipation versus DOS, the difference in management. If any of you went to the talk, I can't remember if it was yesterday or the day before, on constipation by Christopher Velez, it's going to mirror a lot of what he said. If you didn't, and you can find it online, I would recommend listening to that as well. I thought he laid things out very well. I will say that I take a very practical approach. I'm a practical kind of guy. We're going to go through a lot of nuanced definitions with constipation and a little less nuance with DOS, but I like to think of constipation as an apple, and yes, I did bring props, and distal intestinal obstructive syndrome, or DOS, as a lime. And I know somebody's going to come up to me afterwards and explain that limes are very complicated, but I'm going to simplify things and say that apples, being from the Midwest, now is the time of year where we all go to the apple orchard and we pick out apples. And if you haven't done that, it's a lot of fun. But you'll learn that there are a ton of different kinds of apples. There's Gala, Fuji, Jonathan, Golden Delicious, Red Delicious, et cetera, et cetera. This one happens to be my favorite. It's a Honeycrisp. Interestingly, it was developed in my home state of Minnesota. But essentially, when I look at apples, it's an apple. You know, who cares what kind it is? It's an apple. And I think of constipation the same way. You could define constipation in many, many different ways, but ultimately it's just constipation. Whereas DOS is a lime. I can't think of any varieties of lime other than maybe key lime, but essentially a lime is a lime is a lime, and DOS is sort of the same way. There's not a whole lot of varieties to it. But with that said, we'll get into the presentation. These are my disclosures. None are relevant to this presentation. I'd like to remind everybody that there are 2 supplements out there that are GI focused in relation to cystic fibrosis. The one on the left was published in 2017, and then the one on the right is an updated version of that was just published online. And if you remember nothing else from my talk, remember that there is a new supplement in pediatric pulmonology, which lots of GI-focused providers contributed to and has a lot of good information, and we are going to reference that throughout the talk. So, like I said, constipation is like an apple. There's lots of different ways you can look at it, but ultimately, constipation is constipation. And the European Cystic Fibrosis Working Group defined it relatively straightforward, where there's certain criteria, and if you meet these criteria, you have constipation. Number 1 being abdominal pain and or distension. Number 2 being either reduced frequency of bowel movements in the last few weeks or months, or increased consistency of stool, meaning the stool is much harder. And then the third thing is you could either number 1 or number 2, or both, are relieved by the use of laxatives. So that's a pretty simplified, good definition to go into your patient room with in terms of knowing what constipation is. Us as gastroenterologists, especially people who specialize in motility, no offense if people specialize in motility in this room, but we really like to get very granular about how we define constipation. And the way we do that is through the Rome Foundation, which has many, many types of definitions for constipation. One of them being at the lower part of the slide, and just to go over the nuance of it, it must include 2 or more of the following. And the caveat with this is the criteria fulfilled for the last 3 months with symptom onset in the last 6 months prior to diagnosis. And you could have you have to have 2 or more of straining during more than 1/4 of defecations, lumpy or hard stools, which Bristol, if anybody knows the Bristol stool scale, good, that's great. Bristol stool form scale 1 to 2 of more than 1/4 of the defecation, so on and so forth. I'm not going to read the whole thing, but you can imagine how nuanced these definitions of constipation get. And then we get into kids, and I'm an adult provider, so I don't take care of kids too often, but children have even more nuanced definitions. Again, must include 1 month of at least 2 of the following for infants up to 4 years of age, and then in toilet-trained children. You can see how bulky this criteria gets. Fortunately, our friends across the pond in the UK, the National Health Service, has very nice, clean definitions, and this is essentially what I use. 1, because they use the word poo, which is a lot of fun for gastroenterologists. We have the best jokes. But 2, I think it's a very practical definition. So they have both definitions for adults and kids, and this is essentially what I use in clinic. So it's likely to be constipation if you have not had a poo at least 3 times during the last week, or you're pooping less than normal. The poo is unusually large or small and is dry, hard, or lumpy. You are straining or in pain when you have a poo, and you feel like you haven't fully emptied your bowels. So I think when we look at constipation, you can be nuanced, and I'm repeating this over and over again because there's a lot of debate amongst gastroenterologists. How do we define constipation? And if we're debating how we expect the community as a whole to learn how to not only identify constipation but treat constipation, it can be very confusing. So trying to be as practical and as simplified as possible, in my opinion, is probably a good way to go. So that's adults. Kids, your child may be constipated if they have done less than 3 poos in the last week. Again, the poo is large and hard. Their poo looks like rabbit droppings or little pellets. They're straining. They may or may not have some bleeding, and they have a poor appetite or stomach pain. So again, pretty straightforward, simple definitions, and I would encourage you to, again, listen to Dr. Velez's session from the last day or 2 to get more into the definitions. Distal intestinal obstructive syndrome, on the other hand, is like our Lyme. It's very much straightforward. So again, the European Working Group has a good definition. There's 3 criteria. For complete DIOS or complete obstruction, you need all 3. For incomplete, you need number 2 and 3. So number 1 is complete intestinal obstruction as evidenced by vomiting or bilious material and or fluid levels in the small intestine on radiography. Number 2 is fecal mass in the ileocecum, and number 3 is abdominal pain and or distension. Constipation has a pretty broad differential, but it all kind of leads back to the underlying problem of essentially having less stools than normal, less poo than normal, and the stool is hard and doesn't necessarily get out all at once. Whereas the differential for DIOS is fairly broad. You can have surgical issues, you can have acute exacerbations of chronic illness, you can have other things, and the differential is listed on here. But the main thing that separates DIOS from constipation is the acuity and the severity. If you ask people who've had distal intestinal obstructive syndrome, they know what that feels like. When you ask people who have constipation what it feels like, it can vary from person to person, it can vary from day to day, things like that. And oftentimes constipation leads into DIOS, but DIOS is much more acute, it's much more severe, and as we'll talk about, it will prompt an emergency room visit, whereas constipation usually does not. So again, constipation versus DIOS, the onset gradual versus acute. Severity can be variable with constipation where it's pretty severe. In DIOS, obstructive symptoms, maybe a little mild obstructive symptoms in constipation where you feel very bloated, backed up, distended, you don't want to eat, and then you have a bowel movement and that might get better. Whereas DIOS, yeah, you're not going to want to eat, you do not feel well. And then imaging, we'll go over the imaging, but in constipation, you get stool pretty much isolated to the colon, whereas in DIOS, you get stool that is more isolated to the distal small bowel. So constipation management, this again is in the new supplement, the flow chart. I'm not going to dwell too much on the algorithm because we're going to talk more about the algorithmic approach to DIOS, but with constipation, there's lots of different ways that you can define it like we talked about, but basically once you've defined it, it's suggestive of constipation. Your next step is to look for red flag symptoms. Really, basically, you want to differentiate what's constipation versus what could not be constipation, such as a blockage from cancer and things like that. So you look for rectal bleeding, abdominal distension, vomiting, weight loss that's unintentional, things that are important in the family history, and that may lead you away from constipation and towards something else, again, such as cancer, such as inflammatory bowel disease, things like that. And if you do have these red flag symptoms, then you're going to do more of a workup in terms of figuring out what's going on, CAT scans, colonoscopies, things like that. But if you don't have those red flag symptoms, you can go into essentially treating constipation. I want to emphasize this. You do not need a colonoscopy for somebody who is constipated. You don't need to do a colonoscopy unless they either have red flag symptoms or they're of the age per our CF guidelines for colon cancer screening, in which case, yes, do a colonoscopy. But if you have somebody in their teens, 20s, 30s who has less bowel movements than they want, or their bowel movements, they just feel like they're not emptying well enough, you don't need a colonoscopy for that. Again, it's very individualized, and this day and age, individualized care is paramount. But in general, you don't need a colonoscopy. You can start treating. Treatment involves a number of different things. First and foremost, PEG. PEG is our foundation as gastroenterologists, giving polyethylene glycol, which brand name, I don't like to use brand names too often, but we all talk about it. Brand name is Miralax, but I'll call it PEG from here on out. PEG is our foundation. Lactulose used to be a foundational drug. My own personal opinion, I never give lactulose. Lactulose causes a ton of bloating. Lactulose is good for hepatic encephalopathy, and that's about it. So some people, I'm sure, will get up on the microphone and argue, oh, lactulose is really good, things like that. And that's, everybody's different in terms of their approach. My approach, I use Miralax, I said I wasn't going to say that again. I use PEG as my foundation, all right? Then you can move on if PEG doesn't work, and you can dose PEG every day, multiple times a day. People ask, can I use PEG indefinitely? Yes, I give it to my children all the time. They call it pepper. I have no idea why, but whatever. But PEG is safe, it's effective, and it's safe. But when it's not effective, we have other things that we can use, and we are doing trials that are CF specific, because none of these trials really incorporated CF into their inclusion criteria. But we're starting to do more CF specific trials looking at things that are secretagogues, which basically try to shift water into the lumen of the intestine. Those are things like lubiprostone, linaclotide, plecanatide, so on and so forth. We're looking at prokinetic things that essentially increase motility. Those are things like protostigmine, prucalopride, senna, things like that. There is a new thing where you can take a pill that vibrates and it sort of stimulates bowel movements as well. Not many people use that, but again, that's something that's going to come on the market and be more common. And then if none of those things work, then we have other things that we can offer. And again, I will point you, and yet another plug for Dr. Velez's talk, towards more structural or neuromuscular issues when it comes to constipation in the pelvis. In the pelvis, you can get issues where the rectum, or the last part of the colon, as well as the muscles surrounding it, won't let you sort of uncork that cap and get stool out. He did a really nice job with an analogy of a toothpaste. A tube of toothpaste, where sometimes you don't get the squeeze and sometimes you can't unscrew the cap. And I really like that analogy. And if you use all these medications and it doesn't work, or you have somebody who's constipated and they have to manually go in and dig the stool out, and yes, people do that. I hate hearing it, but I'm glad that people tell me, because it's a very personal thing. Nobody wants to admit that they go and pull their own stool out, but it does happen. If that's the case, and please ask your patients if they do that, because they're not going to readily admit to doing it. People will not say that unless you specifically ask them. If that's the case, then you need to work on the musculature of the pelvis through physical therapy, biofeedback, things like that. So that's sort of the management of constipation. I'm not going to get into the details of what medication you use when, because we really don't have that data specific to cystic fibrosis, and my hope is that we have that data in the next several years. But right now there's a variety of different things, but in my opinion, the foundation is PEG. So again, just to get into the little nuts and bolts of constipation management beyond PEG, lifestyle things, make sure your patients are hydrating, hydrate. The colon is the world's greatest hydration machine. It sucks out all that water from stool if you're dehydrated, leading to those little rabbit pellets. And then dietary things, I use kiwi fruit a lot, or kiwis. There's good emerging data over the last couple of years saying that kiwis are probably better than prunes, 2 kiwis a day. Again, laxatives, and then specific things for constipation. Don't forget about that. This is where the Rome Foundation really gets into the nuts and bolts of it. If your patients are taking opioids, you can have stasis from opioids, and you can use peripheral acting antagonists, again, pelvic floor disorders. And then don't forget about electrolytes. Electrolytes can really impact the musculature of your intestine. And then fixing those electrolytes, especially calcium, don't forget about calcium, can really help. This is our management for DIOS, and I'm done. I'm kidding. We're going to go through this. This is the algorithm that was presented. Please don't take pictures because you won't be able to zoom in. I'm going to go through this on all the slides. But if you remember in the supplement that we mentioned, both supplements have this figure. But we'll go through this real quick. So if you have a person in your clinic with cystic fibrosis who calls you or comes to clinic or messages you saying, terrible abdominal pain, I don't want to eat, I don't know what's going on, or I feel like something is happening, and you're concerned, you flush out that there's obstructive symptoms, your next stop is to ask for more alarm symptoms to make sure that there's no emergency that's happening, fevers, chills, weight loss, jaundice, icterus, things like that. That's really going to help you see if there's something else besides just DIOS or bad constipation that's happening. If there are alarm symptoms, look for other diagnoses. Again, there's a broad differential. But if there's no alarm symptoms, you really need to see if this is just worsening constipation or not. Because again, many people who have distal intestinal obstructive syndrome have underlying constipation. So is this just bad constipation, or is there something else happening? Are they actually obstructed? And that oftentimes is difficult to tell unless your patient is having true abdominal pain, again, something that's new, something that's worse, and that really helps differentiate what's happening in your patients if they have underlying constipation. So if this is constipation, just treat it, but if it's not, you're worried something else is happening, again, really bad abdominal pain, obstructive symptoms, then you're gonna wanna send them to the emergency room. And again, the signs and symptoms of DEOS: complete obstruction, nausea, vomiting, they're throwing up, presence of a fecal mass. You may not be able to tell this over the phone because most of our people who we see in clinic don't have x-ray machines at home. So number 2 doesn't really apply if you're talking to them, but if they go to urgent care or something like that and they get an x-ray, we really want to look for something in the ileum. And again, presence of moderate to severe abdominal pain. These are people who you're not going to want to treat at home. You're going to want to send them in, either see them in clinic or to urgent care or the emergency department. First and foremost, you're going to want to get imaging. You're going to want to see what's happening in the belly. We image people all the time, and radiation exposure is a problem. However, if you're worried about DEOS, you're going to have to tolerate the radiation exposure because that can become a surgical and life-threatening emergency. So you're going to want to image either abdominal x-ray or a non-contrast CT just to see what's happening. You're going to want to initiate supportive care like you would anybody else who has an obstruction. And then get your gastroenterologist involved if you have one, get your surgeon involved if you have one. Really try to get help so that we can not only provide support, but also pivot if we see something that is alarming or we think the diagnosis is off base. Peritoneal symptoms on exam, the easiest question to ask in order to figure out if there's peritoneal symptoms. Peritoneal symptoms are basically you have inflammation on the serosal side of the bowel or a surgical emergency. Your intestine is about to explode, so to speak, or has already. The easiest question to ask is, how is the car ride over? How did it go? And most people be like, oh, it was fine, no big deal, traffic stinks if you're in Chicago. Or it was the worst pain of my life, every bump we went over, it was awful, it was terrible. That's peritoneal symptoms. So if that happens, surgical management, get your surgeon involved early and often. If not, image, look for obstruction. Look for air fluid levels. It's the staircase. These are air fluid levels where essentially you sit your patient upright, or if they can stand, and you look for these little staircases on their belly film like shown in the x-ray. If there's air fluid levels on imaging, again, that means that there's an obstruction. If there's not, it still doesn't rule out obstruction. It could be very early on. If there are air fluid levels, treat them as if they have an obstruction, NG tube dissection, and get them feeling better. And then the overall management of DEOS is as following. So if your patient can tolerate things going in from above, so say you put that NG tube down or you have them sip some water and they feel okay, treat from the top, give them, again, peg through the top, whatever your bowel prep is. Give it slow because you don't want to overwhelm the system and then create an obstruction. Give it slow. People also advocate potentially using water-soluble contrast through above, but the mainstay is below, okay? You really want to uncork that obstruction and giving water-soluble contrast, and I'm going to use another brand name. I'll use it once. Hopefully, I'll only use it once, but at our institution, we use a water-soluble contrast called gastrographin, and what happens is if you give an enema of water-soluble contrast, and your radiologist does this under fluoroscopy, and you have to do it under fluoroscopy in order to make sure it gets up through the colon, up into the small intestine, that water-soluble contrast really breaks up the stool that's sitting in the small intestine. And DEOS is basically, you have all this gunk, this mucus that accumulates and basically turns into what's called inspissated stool or dehydrated mucus. It's just sitting there right in the last part of the small intestine, or where the small intestine meets the colon, or in that first part of the colon. And it's really hard to get that rock hard mucus, that inspissated stool, out. That's what causes the obstruction. And this water-soluble contrast really helps break that up. And again, the mainstay is water-soluble contrast through an enema, or I should say, again, above. We tend to start below, and then if they can tolerate it, from above. And then our mainstay, again, we're coming back to it, is PEG. We give as much PEG as somebody can tolerate. So air fluid levels, again, NG tube, and then treat them. So whether they have an obstruction or not, the management is essentially the same, except for if they don't have an obstruction, you can be a little bit more aggressive, but please don't put 1,000 milliliters into somebody's stomach at once. You really want to be careful. If there's no response, do it again. If there's no response, do it again. You can do that a few times to try to get things moving. Your radiologist will not be your friend. They do not like doing this. But it's one of those things where a personal conversation, call them up and be like, look, I have this person, they're really sick, we need to do this. It can be very, very helpful to have a one-on-one conversation. And then if they're feeling better, keep going with the PEG. You really want to essentially do a colonoscopy prep for people who are having DEOS. Get everything out, all right? And then you can confirm whether or not stool is still left in there with an X-ray if you want. Has bowel function returned? Yes. Supportive care, get them on a bowel regimen, things like that. No, again, repeat a couple times. And then ultimately, if your symptoms get better within 24 hours, hopefully they can go home. If they're not getting better, this is where your gastroenterologist, your surgeon can help to see whether or not ultimately they need to go in and either do a colonoscopy. This is where colonoscopies can come into play to clean stuff out. Our gastroenterologists will decide if that's safe or not. And then a surgeon, they can decide, you know what, they're not getting any better. We have to go in and surgically either remove this area or clean it out, do an intraoperative colonoscopy, things like that. But that's where collaborative communication and collaborative decision-making can be very helpful. So if improvement with 24 hours discharge, no. Is there something else going on? Do we need to go and do a colonoscopy, things like that? And that is it. I think we're going to do question and answers at the end, but I thank you all for your attention.
Thank you, Dr. Stein. Next up, and we have Dr. Shilpa Sood, who's an assistant professor of pediatrics at the Maria Ferrer Children's Hospital in Westchester Medical Center in Valhalla, New York.
Thank you. Good morning, everyone. Thank you to the moderators for inviting me here today. After an exciting talk about the apple and about high fiber diet and obstruction in the lower GI tract, we're going to shift gears a little bit and go to the upper GI tract. And today I'm talking about delayed gastric emptying, its evaluation and management. I have no disclosures. So what is gastroparesis? It's a chronic motility disorder, and there are symptoms of delayed gastric emptying in the absence of signs of mechanical obstruction in gastric outflow. And this has to be excluded by imaging and by endoscopy. Patients usually present with symptoms of nausea, vomiting, they have postprandial fullness, they have bloating and abdominal pain. Somehow there's a lot of overlap between symptoms of gastroparesis and functional dyspepsia. Why is this important to us? Because patient symptoms negatively impact their quality of life. And this is increasing healthcare utilization, where patients end up in the emergency rooms, there's multiple hospitalizations. Now, coming to the prevalence, it's been studied that the prevalence of gastroparesis in patients with cystic fibrosis is much higher than the general population. This was a meta-analysis of 6 studies that reported the pooled incidence prevalence rate in patients with cystic fibrosis to be around 38%. It also found that the incidence is much higher in patients post-lung transplantation. They found that the incidence was as high as 75%. There was increased incidence, prevalence of gastric bezoars in these patients, more higher complications of bronchiolitis obliterans syndrome, of chronic lung allograft dysfunction. So early diagnosis and management could prevent these complications. Now, coming to the role of modulators. Now, was there any effect on motility? And studies looked at ivacaftor, pre and gut motility, and they didn't find any difference in gut motility and gastric emptying pre and post ivacaftor. Now, this is our GALAXY study, and it's greatly represented the symptoms of patients with cystic fibrosis. And if we look at this, after constipation, the most common symptoms that patients reported was stomach fullness. They reported bloating and stomach being visibly large. And these are symptoms that are seen in patients with gastroparesis as well. The etiology of gastroparesis in the general population is multifactorial, and so is the case with cystic fibrosis, but the most common causes in patients with CF is CF-related diabetes, any surgical conditions that can cause injury to the vagal nerve, that is post-transplant or post-fundoplication, medications, opioids, they can worsen gastric emptying, and glucagon, like GLP-1 analogs that are used in the treatment of diabetes. Coming to the pathophysiology of gastroparesis. So first, let's learn what the normal physiology of how gastric emptying occurs. So in response to food bolus that enters the stomach, the first step that happens is receptive relaxation of the fundus. That's called gastric accommodation. After that, the phase of gastric peristaltic waves that's initiated by the interstitial cells of Cajal. Once these peristaltic waves go through, then the pyloric channel opens up under neurohormonal influences. Now, if there is a defect in any of these three mechanisms, that results in delayed gastric emptying. In patients with cystic fibrosis, if defects in accommodation and pyloric sphincter abnormalities have been hypothesized as the most common cause of delayed gastric emptying, and this was believed to be due to a defect in the neurohormonal dysregulation feedback mechanism. So now, how do we make a diagnosis? We know that the symptoms are prominent, these patients have a higher prevalence. What can we do? How do we identify them? First thing is when patient presents with symptoms that look like gastroparesis, we want to rule out mechanical obstruction, which could be by imaging, which includes ultrasound. It could be a CAT scan. They need an upper endoscopy to rule out outflow tract obstruction. Once obstruction has been ruled out, then gastric emptying scintigraphy study can be performed. This is a gold standard. It's a 4-hour technetium 99 label solid phase study. Now, American College of Gastroenterology really updated their guidelines in 2022 on the diagnosis and management of gastroparesis, and they recommend that it should be at least preferably a 4-hour study, and gastric retention of more than 10% at 4 hours is diagnostic of gastroparesis. So classically at gastric emptying study, the way it is performed is the patient is fasting overnight, they come in the morning, we should check their glucose level, especially with patients with diabetes, to make sure their sugar levels are below 275, ideally, because that can alter the test results. They're given this standardized meal with technetium 99, it's scrambled eggs with 2 slices of toast, jelly sandwich, sounds really enticing and makes me hungry, and then they have to drink water, and then they're taking the radioactive material and the amount of gastric contents every hour. So at 4 hours, if the retention is more than 10%, that is diagnostic. Now, the downsides is that not every center has a nuclear medicine scan. A lot of centers have solid phase studies that are protocolized only for 2-hour studies and not 4 hours, which is not ideal in diagnosing gastroparesis. So in those cases, we could use another non-invasive study, which does not require going to a hospital, sitting there for 4 hours. That does not require you to ingest a radioactive material. So in that case, the FDA approved this test, that is the C13 spirulina breath test, that's the gastric emptying breath test, in 2016. And this test works very similar to the gastric emptying scan, where the patient receives a packet. I don't know if you can see my pointer. Yeah, this is dehydrated scrambled eggs with spirulina C13 label. Sorry, it doesn't sound fun, but patients get to cook this meal in their microwave, and then they ingest this meal in 10 minutes, and they have to collect breath samples every hour for 4 hours. And they can drop this to the lab, and now it is a problem of the physician. And and to figure it out. So the way this test works is that the meal is ingested. After this food is emptied into the stomach, C13 is digested. The spirulina is digested. C13 that's now exhaled out can be tested in the breath sample. So we expect that at 120 minutes to 150 minutes is when you see a peak of the C13 levels. And by 240 minutes, the trend, it should be a downtrend. That's normal gastric emptying, which is about 2 to 3 hours. But if the graph is reversed, where you see that the C13 levels are higher at 240 minutes, that is suggestive of delayed gastric emptying. But patients who could have allergies to egg, who could have an allergy to spirulina, may not be able to do this test. So that's one downside. Wireless motility capsules, these were widely used for a period of time, but now they've fallen out of favor and they've been pulled out of the market in the past 1 year. But it was a good test to look at global transit time. It was giving us more information in terms of pH, in terms of temperature and pressure. Radiopaque markers, these are widely used when we talk about transit times, especially when we talk about colonic transit times, but they have not been useful in studying gastric emptying times. Now we come to electrogastrography. Not every center is equipped to use electrogastrography. This is a very specialized test. It's a non-invasive test. It does not give us any information about gastric emptying, but it does tell us about what the function of the pathophysiological mechanisms in gastric emptying function is. So it is, what did I do? So it's a non-invasive test where you have leads that's placed on the abdominal wall and it's looking at tracing. So it gives us the myoelectrical activity in the stomach. Full thickness biopsies were used initially, but they didn't really give us a lot of information. They do tell us that interstitial cells of Cajal may be missing or the number of cells are less. So it is now reserved only for research purposes and to identify biomarkers, but it doesn't really help us in clinical management. There were studies looking at functional MRIs to assess orocecal transit time, and these have been used in patients with cystic fibrosis. But they may give us some idea of the gastric emptying time. We need more studies to say that is this something we want to do in our patients with CF. EndoFlip is a new technique. This is endoscopic function lumen imaging probe. This is an invasive study. It's an endoscopy. So the patient is under endoscopy, a catheter is passed. It has a balloon at its tip, and the balloon is inflated to about 30 cc's or 40 cc's. And this was initially deployed only for esophageal disorders, but now it's increasingly being used for pyloric dysfunction. So when a patient has symptoms suggestive of gastroparesis, once you inflate the balloon the equipment is giving us information about the diameter of the pylorus. It is giving us information about the compliance. So this is being translated in the form of what we call a pyloric distensibility index. So if your pyloric distensibility index is high, it suggests that there are abnormalities in the pyloric sphincter. And this is a great guide to tell us that these patients would benefit from pyloric intervention studies like a pyloromyotomy. And I'll talk a little more in detail coming up. So now what do? We've made the diagnosis of gastroparesis. Now we need to find the underlying etiology and maybe we can treat them. If the patients have diabetes, glycemic control is very important. And there are studies, and we heard about it at the plenary yesterday as well, that hyperglycemia or elevated hemoglobin A1C levels are associated with delayed gastric emptying. And that is the reason when patients come in for a gastric emptying scan, these patients should get a glucose check at that time, that if their sugars are high, above 250, maybe the test results will be abnormal. So good glycemic control is important. We treat any underlying condition they might have because they could be coexisting ARFID, eating disorders, they could be anxiety, they could be cyclic vomiting syndrome, they could be coexisting conditions, irritable bowel, that may exacerbate their symptoms. In general, the management of patients of gastroparesis in patients with CF is very similar to the general population, but we need to pay special attention to their comorbidities, to the risk factors, and the multiple other medications that they're on, and the drug interactions when we are trying to treat their symptoms. And in a nutshell, what would we do? First thing we do, especially when we have a patient with CF, and they have symptoms suggestive of gastroparesis, assess their nutritional status. Do they have any underlying nutritional deficiencies that need to be corrected? Do we need to make sure they're hydrated? dietary modifications are the first-line therapy that everybody would recommend. And if dietary modifications don't work, they usually need adjunct therapy with medications to help their symptoms, to help improving gastric emptying. And if this doesn't work, then we resort to endoscopic measures. A lot of patients may not be able to tolerate oral feeds. They may need gastrostomy tubes. They may not be able to tolerate gastrostomy feeds, and they may need gastrojejunostomy tubes, where the G tube is used for venting and a J tube is used for post-pyloric feeds. And this intervention of GJ tube feeding has proven to be very beneficial and very well tolerated in patients with gastroparesis and helps in improving weight loss. Endoscopic measures are very helpful, and then surgical measures are reserved for patients who are refractory to medical therapy. Now, how do we assess that patient? Is the patient getting better, or is the patient not getting better? So since the symptoms do not correlate with the degree of impairment that is seen on diagnostic testing. So we have GCSI scores. This is a gastroparesis cardinal symptom index. They help in predicting the severity of symptoms, and they predict response to prokinetics. Initially, it was based on a 2-week recall, but then recently the Neurogastroenterology and Motility Society came up with the daily score, and it includes symptoms of bloating, nausea, inability to finish a meal, feeling of excessively full after meals, and presence of upper abdominal pain. And it is scored on a scale of 0 to 4. So higher the scores, higher is the severity of symptoms. Now, we don't use this in regular clinical practice, but it is very useful in clinical studies to help in understanding the efficacy of medications. Now, how do we talk about dietary modifications? Patients are already losing weight, and then we are coming up with dietary modifications. And what is the basis for this? So this was a study that had about 56 subjects with diabetic gastropathy, gastroparesis, and they were divided into 2 groups. One was an intervention group, and the other was a control group. What did the intervention group get? They got a small particle diet. How do you define small particle? 2 millimeters. Nobody is measuring 2 millimeters when we are eating food. So any food that could be mashed with a spoon and was a mashed potato consistency, didn't have a crunch when you were eating, or could be a soup consistency, that was in the intervention group, and the control group was allowed to eat whatever they wanted. They followed these patients for about 20 weeks, and then they gave them these GCSI scores to look at their symptoms. And they found that there was a statistically significant improvement in their symptoms of nausea and vomiting, in their symptoms of postprandial fullness, and in symptoms of heartburn and regurgitation. Their anxiety improved. There was an improvement in the quality of life. What did not change was abdominal pain and still the feeling of bloating in these patients. So that's how the dietary recommendation came up, that a small particle size is very well tolerated, and these patients should be recommended. The other dietary recommendations that we make are based on the normal physiology of gastric emptying. So we know that liquids empty faster than solids. Even in liquids, low energy, low calorie liquids, just water versus Ensure, clear, there is a difference in emptying. Water empties faster than Ensure. If we look at, in a healthy patient, low-fat foods compared to high-fat foods, there is a difference in emptying. So in patients with gastroparesis, that is the basis, that we are using low-fiber diet, we are using low-calorie foods, we are using a small particle size. And that is why that is our first-line therapy, first-line recommendation when we have patients with gastroparesis. Some of them may not respond, and a lot of them do not respond just to dietary modification, and we might resort to medications. And there are medications available that improve gastric emptying. There are medications that are required for symptom control, because they could be predominantly nausea or vomiting, or they could be a category where they have severe abdominal pain. So metoclopramide is the first-line prokinetic therapy, and unfortunately is the only FDA-approved drug at this time available for use in gastroparesis. It is a very potent dopamine receptor antagonist, which improves gastric emptying. It is a potent antiemetic, which because of its action on 5-HT3 receptors and on the chemoreceptor trigger zone, and it is a weak 5-HT4 receptor agonist, which releases acetylcholine and improves gastric emptying. The dose is, unfortunately, it's limited use. FDA has allowed us to use it up to a duration of 12 weeks, limited use to patients who are less than 65 years of age. And it has a black box warning of tardive dyskinesia. They felt that there were studies looking at which formulation works better, and oral liquid formulation is preferred over the tablet form. And now they came up with the intranasal spray, and this was a study that was a placebo-controlled study that compared metoclopramide nasal spray in women with diabetic gastroparesis to placebo, and they found that over a 4-week period, there was an improvement in their symptoms of gastric emptying. When they looked at the total abdominal scores, they improved. When they looked at their nausea scores, there was an improvement. and their total GCSI scores also improved. Coming to the side effects of metoclopramide, there have been studies. So when FDA came out with approval for metoclopramide, when you look at their packet, they say the risk of tardive dyskinesia is about 4 to 10%. But there were subsequent studies that were done looking at neurological side effects, and they found that patients did have some reversible neurological symptoms that were not tardive dyskinesia. So when they looked at the incidence of tardive dyskinesia, they found that it was less than maybe 1%, which is different from what the FDA packet says. The other group of drug that is in the same class as metoclopramide is domperidone, and this is a systematic review and meta-analysis of comparing the two, and they found that it's equally efficacious. It does not have the CNS side effects of metoclopramide, but it does have significant QTc prolongation, and it causes sudden cardiac death. It is not available in the United States. It's available in Canada and Europe. And the only way we can get it in the US is through an IND with an IRB research protocol, which includes frequent EKG monitoring. It does have some drug interactions, and that is the reason why we need close monitoring with any other drugs that the patients may be on. The other class of medications that we do commonly use is motilin agonists. This is erythromycin, which has been around for decades, and we have been using it, and the promotility dose is much lesser than the antibiotic dose. Azithromycin, that is used commonly in patients with cystic fibrosis for the treatment and for anti-inflammatory effects, that has some promotility properties as well. The limitation is that this medication should be used can be used only for less than 4 weeks because of tachyphylaxis. But giving them drug holidays, having a washout period may definitely improve our chances of reusing the medication. Patients who are on CFTR modulators, patients who are on calcium channel blockers and antifungals, the doses need to be adjusted due to drug interactions. The new class, which is not used as a first line, but as we have an off-label use, everybody uses it off-label for the treatment of gastroparesis, is the 5-HT4 receptor agonist, which includes prucalopride, mosapride, levosulpiride, velocitrag. These drugs are not available in the United States, but we all know prucalopride very well. Prucalopride has been approved for the treatment of constipation, and this was a double-blind controlled crossover study which compared 2 milligrams of prucalopride to placebo over a 4-week period, and they looked at their GCSI scores, and there was a significant statistical improvement in their symptoms. They looked at their symptom scores in detail, and they found that there was an improvement in their symptoms of nausea and vomiting, in their symptoms of fullness and early satiety, and their overall quality of life was improved. But there was no improvement in their symptoms of bloating. So there was another study said, let's try a higher dose of prucalopride. So they used 4 milligrams of prucalopride, compared it to placebo, and over a 4-week period, and they gave them symptom questionnaires. They looked at gastric emptying time, and there was an improvement in gastric emptying time. When they looked at meal-related symptoms, there was no improvement in meal-related symptoms in this group of patients, which corresponds with abdominal bloating and postprandial fullness. So if we have patients, and a lot of our patients with CF have constipation, so patients who have concomitant constipation and symptoms suggestive of gastroparesis, prucalopride is a great drug. But we need more studies to look at its safety profile in patients with CF and as a primary indication for gastroparesis. It does have a black box warning of suicidal thoughts, so that is one of the side effects of the something to watch out for. Ghrelin receptor agonist, this is the new medication that's being studied. It includes relomorelin and TZP, which is now in phase 2. Phase 2 studies have shown promising outcomes. They have minimal cardiovascular and neurological side effects. So there's more data to still come on about this group of medications. Interestingly, so patients with gastroparesis do have these acute flares where they have severe abdominal pain, they have severe episodes of nausea and vomiting that warrants them to go to the emergency room and may require admission after that. So there was a study looking at giving haloperidol 5 milligrams. It was a controlled study. There were 33 patients who were given haloperidol, and the control group received routine treatment, and they looked at what would be their doses of morphine after haloperidol and after regular treatment, and what was their hospitalization rate. And it was very interesting that the group that received haloperidol had a lower requirement of morphine and lower hospitalization rate. So the American College of Gastroenterology in their latest guidelines recommended that haloperidol can be used as a short burst in the treatment of acute abdominal pain or nausea and vomiting when patients present to the emergency room only. Now, symptomatic control. Now, symptoms are very debilitating in patients with gastroparesis, and this has significant effects on their quality of life. And I think we're falling short of drugs to help in improving their symptoms. So out of the antiemetics that we have promethazine, we have prochlorperazine, we have ondansetron, we have aprepitant, and we have scopolamine patches that have been useful. In central neuromodulators are useful in patients who have refractory vomiting, and tricyclic antidepressants of those have been very useful. And this was a study that looked at nortriptyline and its effects in compared to placebo, and they found that when they gave escalating doses of nortriptyline up to a max dose of 75 milligrams over a 3-week period, compared it to controlled studies, control group, and they watched these patients over a period of 12 weeks, they found that there was a significant improvement in their symptoms of abdominal pain. Amitriptyline there are some scattered reports saying that amitriptyline actually decreases gastric emptying, and it actually improved symptoms of abdominal pain in patients who had functional dyspepsia, and it didn't really show a difference in outcomes in patients who have gastroparesis. When we have patients who have weight loss and they have a loss of appetite with their symptoms of gastroparesis, mirtazapine has been a very useful drug. There are many other drugs that are still being studied. I thought this was an interesting comparison where they had about 129 patients, and they compared patients who were on prokinetics, on neuromodulators, on a combination of prokinetics with a gastroparesis diet and a combination of prokinetics with neuromodulators. They found that these patients, over a 6-month period, there was a significant improvement in their symptom scores, especially those on neuromodulators and those who were on a combination of neuromodulators with prokinetic drugs. And somehow this response was more prominent in patients who did not have delayed gastric emptying. I don't know how we can explain that, but maybe there's some placebo effect to it, but there was definitely some improvement in symptoms that was significant. For the abdominal pain, of all the medications that we've discussed so far, all of the medications help with nausea and vomiting, and none of them have been really helpful in improving abdominal pain or bloating. So we use a lot of antispasmodic medications like hyoscyamin. We really want to avoid opioids because they delay gastric emptying. But tramadol was studied, and they felt like since it's a weaker opioid, it might be better tolerated, and it doesn't have as significant effects on gastric emptying as morphine or oxycodone does. Complementary therapies have been tried. So there are reports of acupuncture, of herbal therapies with iberogast, along with prokinetics that are used as adjunct. People who have refractory vomiting, medical marijuana has been very useful. It didn't improve gastric emptying time, but it did improve the symptoms of gastric emptying in these patients. And very interesting, and I don't know how we would discuss this with our patients with CF who have pulmonary problems, that smoking cannabis helps your symptoms of gastroparesis versus take the oral route. Now, endoscopic therapies, these are pyloric interventions. So these are pyloric interventions. So EndoFlip that we talked about earlier, that is helpful in the diagnosis or identifying patients who have pyloric sphincter abnormalities. So the way it works is that when there's a catheter, endoscopically a catheter is passed, there's a balloon at its tip that's inflated to about 30 cc's, and then it gives us measurements of pressure. So this blue zone is basically, so if you see darker shades of color, that indicates that's a high pressure zone. So this is what the pylorus here looks like, where there's a high pressure zone. That means there's a pyloric sphincter abnormality in this patient. So this study helps us in telling us that this patient has an abnormality here and we need to try to address it. So there are two ways of doing it. We could do an intrapyloric Botox injection, or we could do a GPOM, which is increasingly being used. Intrapyloric Botox, now, there is no data. American College of Gastroenterology in their latest update did not recommend its use, but there was a meta-analysis of 8 studies, and they found that about 25% they saw only a 25% improvement in symptoms of nausea and vomiting, and there was no real improvement in in their total gastric emptying symptom scores. So that is why they didn't recommend it. Nevertheless, we all try it. And if we do see patients who do respond, and there are a group of patients who do respond to Botox, and it requires recurrent treatment every 3 months. And if patients do respond to Botox therapy, this is an indication that they might do better with a GPOM. So if they still have symptoms after a Botox, do consider a GPOM. A GPOM is gastric peroral endoscopic pyloromyotomy, and this is an endoscopic procedure. You need an interventional gastroenterologist to do this. I would think so. So it's by endoscopy. Here, mucosal incision is made at about 5 centimeters from the pylorus. A submucosal tunnel is created, as you can see right here. And then the pyloric muscles are identified. A pyloromyotomy is performed. And the mucosal defect is closed with endoclips. This study has, so far GPOM has found to be very promising. The results have been great. There have been multiple meta-analyses looking at short-term and long-term success rates, and they have been very promising. So this was a randomized sham control trial of patients who had refractory gastroparesis, and they found that patients who received a GPOM did very well over a 6-month period. Their total GCSI scores improved, their 4-hour gastric emptying times improved. There was a follow-up study that's called the Greg trial, where they followed these patients up to 36 months, and they looked at their recurrence rates. They had endoflips done, and they found that their pyloric distensibility index were much lower, even at 36 months after a GPOM. So it's a very promising study. There are some complications that do occur. They could be GI bleeding, they could be a perforation, there can be pyloric ulceration that can occur. But compared to surgical pyloromyotomy or surgical pyloroplasty, it is found to be superior, and it is less invasive. GPOMs, where now we talked about gastroparesis, incidence of gastroparesis being more in patients post-lung transplant. So GPOM was performed in these patients, and there's a meta-analysis showing that their total GCSI scores and their symptom scores improved. It showed that their 30-day post-op complication rate was much lower, and the 90-day all-cause mortality was low as 2.6%. Surgical therapies, we usually they are reserved for patients who are medically refractory to therapy, which includes a gastric electric stimulator or a surgical gastrectomy. Gastric electrical stimulation, this was approved by the FDA as for a humanitarian use device in 2000, only for patients who have refractory gastroparesis. It is a surgical procedure which requires implantation of the gastric pacemaker, and it is a cumbersome procedure. There were variable test outcomes from the tests looking at the efficacy of gastric electrical stimulation. This was a control trial from the Gastroparesis National Clinical Research Consortium. They had about 300 patients who were randomized to a group that received the gastric electric stimulation and a group that did not. And they followed them over 48 weeks, and they found that their GCSI scores improved and their nausea and vomiting scores improved. And this was the WAVE study. That's how FDA approved it. And they looked at the on phase and the off phase of the gastric electrical stimulator, and they found that the weekly vomiting frequency improved by 1 point in this patient. Given that these patients have such poor quality of life and the variability of response, the recommendation came out that we should do a temporary pacemaker first. If there is an improvement in symptoms, then patients should be subjected to surgical permanent gastric pacemaker. And it is associated with major complications. Since it's a surgical procedure, there can be infections, there could be obstruction, and some people need to get reoperated to actually remove the gastric pacemaker. So in summary, after all that we've talked about, how do we approach a patient with gastroparesis? So when we have a patient who have symptoms suggestive of gastroparesis, first thing we want to look for other causes, rule out obstruction, confirm the diagnosis with a gastric emptying scintigraphy study or a breath test, recommend trial dietary modifications, that's the low particle, low fat, and low calorie diet, consider treatment to treat their symptoms, to help in improving gastric emptying, and if that doesn't help, nutrition, even when we are trying medications, nutritional support becomes very important. They need a very close follow-up with the nutritionist. We could try a Botox in patients who fail medical therapy, or we could try a GPOM. Surgical interventions are again restricted to those who are medically refractory. What is the future? So after we just discussed that we don't have that many drugs available to treat patients with gastroparesis, which is so debilitating and affecting their quality of life, that we need newer prokinetic drugs that have minimal side effect profile, especially for patients with cystic fibrosis who are on multiple other medications and could have drug interactions. We need long-term safety data on GPOM in patients with cystic fibrosis. We need more studies to look at the combination of GPOM and endoflip in patients with CF. We need to look at the role of CFTR modulators and if they do help in improving GI symptoms or improving gastric emptying time. Thank you very much. I would like to thank the Foundation, the NACFC Planning Committee, and Digest, and a big shout out to my CF team at Boston Children's Health Physicians. Thank you.
Okay, our next presenter is Dr. Megan Gable. I'm sorry, that it would tell me more to say, but I'm sorry.
Hi, I'm Megan Gable from the University of Rochester. I'm a pediatric gastroenterologist, and I'd like to thank you for the opportunity to share the stage with my esteemed colleagues and to present on a topic that I find to be fascinating. I have no disclosures. Let's see. Two, okay. All right, so I'll be speaking to you today about small intestinal bacterial overgrowth, the evaluation and treatment, and when to consider this as a cause for symptoms. My educational objectives to share with you include to understand how CFTR dysfunction can result in intestinal dysbiosis, to appreciate the impact of the intestinal microbiome on overall health for people with CF, to recognize signs and symptoms of SIBO in people with CF, and identify methods for establishing this diagnosis, and finally, to develop strategies to treat and potentially prevent SIBO. Starting with the role of CFTR in the intestine, we found that CFTR mediates secretion of chloride, bicarbonate, and fluid. CFTR mRNA is highest in the duodenum and decreases along the small intestine. Bicarbonate secretion is critical for expansion and solubility of intestinal mucus. This contributes to a dramatic shift from what is usually a physiologic acidic pH in the stomach to an alkaline pH in the proximal duodenum. This alkaline pH allows for pancreatic enzyme activation, micelle formation, and fat absorption. The pathophysiology of the CF gut results from the deficient anion and fluid transport. This altered luminal environment impairs turnover and clearance of mucus. This static mucus fosters microbial dysbiosis, which then alters the immune system, and the increased bacterial load then promotes the production of more mucus, exacerbating the initial problem. In talking about the microbiome, the GI microbiome refers to the collective genomes of microorganisms, which can include bacteria, viruses, protozoa, and fungi found in the gut. And in health, most of these microorganisms are found in the colon. At birth, the gut is sterile, but by 3 to 5 years of age, the microbiota has reached a fairly stable composition that can be difficult to alter and may explain why initial studies with CFTR modulators don't show differences after short amounts of time. It's been well described that people with CF have an altered microbial balance and low alpha diversity starting in infancy. A partnership in health, this is a symbiotic relationship that we have with our microbiome. It's important to help maintain gut epithelial layer, resist against colonization of pathogens, synthesize essential vitamins and nutrients, regulate fat metabolism, modulate the immune system, and break down indigestible carbohydrates into short-chain fatty acids, which provide valuable nutrient for the gut. And as you can see, there's a variety of inputs and results that can affect disease and health with our gut. Metagenomics is a method to determine what microbes are present in a bulk sample and the relative abundance compared to healthy controls. Manner et al. Found that in people with CF, they have a dysbiosis that's characterized by an abundance of proteobacteria and actinobacteria, and a decrease in Firmicutes, Bacteroides, and Vermicrobia. I've colored these red and green because a lot of the green bacteria are associated with more positive health outcomes, whereas the ones in red may be more negative. These differences correlated with increased fat, malabsorption, and inflammation in the gut. Now, there's a concept of the gut-lung axis, which suggests that the gut microbiota can influence the course of underlying lung disease, and vice versa. Decreased gut microbial diversity has been associated with an increased rate of pulmonary exacerbations and lower FEV1. Colombo et al. Showed us that breast milk feeding for infants with CF had a powerful impact improving microbial diversity of both the intestinal and respiratory tract, delaying the time until the first pulmonary exacerbation and colonization with Pseudomonas, reduction in the decline of pulmonary FEV1, and decrease in the number of pulmonary infections in the first year of life. So clearly it's the gut and the lung are interacting. Similarly, there is a hypothesis that suggests that gut dysbiosis and the resulting intestinal inflammation may permit bacterial translocation into the portal circulation, leading to hepatic inflammation and fibrosis. Duong et al. Investigated the role of microbiota in people with CF with and without advanced lung disease. And interestingly, they found a higher abundance of pro-inflammatory microbiota in people with advanced lung disease or liver disease. They also noted improvements in dysbiosis and intestinal inflammation after 6 months of treatment with ETI. This evidence supports the link between dysbiosis and intestinal inflammation and CFLD pathogenesis. Now, to clarify here, small intestinal bacterial overgrowth and dysbiosis are different but interrelated entities. Dysbiosis is the imbalance of microorganisms in the gut overall, and small intestinal bacterial overgrowth, or SIBO, specifically refers to the overgrowth of bacteria in the small intestine. And that's what I'll focus on now. So SIBO is a disease state in which there are alterations in the microbial species diversity and intestinal location. In health, overall number of microbes in the small bowel is far lower than found in the large intestine and is predominantly aerobic species. SIBO is defined as a bacterial burden of the small intestine exceeding 10 to the 5th colony-forming units in 1 ml of sampled fluid. And you can see here in the figure on the right how the amount of microbiota increase exponentially from the stomach to the feces. Now, risk factors for SIBO and people with CF are important to consider. There are a variety of different publications out there that estimate the prevalence of SIBO from anywhere from 30 to up to 70%. So certainly this is something affecting your patients. Risk factors, many of which couldn't be altered before, I think we can start to think about altering these in 2024. They might include lower luminal pH, increased viscosity of intestinal mucus, prolonged small intestinal transit time, history of bowel surgery, antibiotic exposure, use of acid-suppressing medications, which historically has been almost 50% in people with CF, and the legacy high-fat, high-calorie diet. Clinical manifestations of SIBO in people with CF include bloating, belching, flatulence, abdominal pain, nausea, diarrhea or steatorrhea, poor weight gain, fatigue, and can be asymptomatic. And now this is really challenging because a lot of these symptoms overlap with other entities, including fat malabsorption, celiac disease, inflammatory or irritable bowel syndrome, to name a few. SIBO can result in deficiency of fat-soluble vitamins, deficiency of vitamin B12, iron deficiency, and deficiency of bile acids. The role of SIBO in nutritional status is important to recognize. Funari et al. Administered a symptoms questionnaire and a glucose breath test to 79 people with CF. Out of these 79 people, 25 were affected by SIBO, a prevalence of about 30%, consistent with many other studies. They found that these people had a lower BMI and albumin independent from their pancreatic status. This suggests that the diagnosis of SIBO should be considered in people with CF and malnutrition, and it may be due to bacterial competition for nutrients, intestinal inflammation, deconjugation of bile salts, or poor appetite secondary to symptoms. One modality of diagnosis that I referred to in the Funari study is breath testing. Advantages is that it is a safe and non-invasive modality. It measures exhaled hydrogen or methane produced by bacterial fermentation of undigested carbohydrate. You can see in the figure on the right that the patient would take a test sugar, and then bacterial fermentation of malabsorbed sugars will produce either hydrogen or methane gas. The gas is absorbed into the bloodstream and exhaled through the lungs. It's important to note that the sensitivity and specificity of this test are not ideal. And in people with CF, methane-producing bacteria have been reported to be 3 times higher than in other subjects. So it's important to include this parameter in testing. As I mentioned, this test can be limited at times due to concurrent antibiotic use for people with CF, the delayed intestinal transit, or gas retention by mucus-plugged airways. The gold standard for diagnosis involves endoscopic duodenal aspiration, demonstrating a qualitative and quantitative alteration in the microbiota. This is not without its drawbacks as well. It's an invasive procedure, and if it done properly, is technically a bit complex and requires proper processing by the labs. Also, in people with CF, the bacteria are much more likely to be found in that thick mucus layer and may not be aspirated. And there's really no protocol in terms of biopsying and analyzing bacteria in that fashion. So in practice, I think many of us would agree that this is often a clinical diagnosis, but it's important that when we make a clinical diagnosis, that it's confirmed by the resolution of symptoms. Now, dialing into some treatment principles, it's largely focused on antimicrobial treatment towards gram-negative and anaerobic bacteria, managing symptoms, and certainly thinking about managing some of those predisposing conditions. This is a table that summarizes some common antibiotic regimens. There are certainly others that may be considered too. When I'm treating SIBO for my patients with CF, I may be talking with my pulmonary colleagues. If a patient's also having an outpatient exacerbation treatment, perhaps we will choose amoxicillin clavulanate if appropriate. Rifaximin is certainly one of my preferred medications because it's a non-absorbable antibiotic that will not contribute to other antibiotic resistance. In the Fernari study that I referred to earlier, they then randomized people with SIBO to either receive treatment with rifaximin or placebo. They found eradication of SIBO was 90% in the rifaximin group versus 33% in the control group, which is quite promising. However, in the US, insurance coverage can sometimes present challenges. If you want to scan the QR code on the right, it's a sample of a letter of medical necessity with some resources that may help get coverage. For people with CF, additional antimicrobial treatment for SIBO, especially as this can oftentimes be a clinical diagnosis, can present a clinical dilemma and certainly add to the burden of care. However, antimicrobial therapy has been shown to improve symptoms for weeks or months. However, considering another condition that requires repeated rounds of antibiotics, again, is challenging. So what about probiotics? Probiotics are known to decrease dysbiosis and improve gut maturity and function. We know that increased colonization by Fusobacterium and Bacteroides leads to gut inflammation in CF. And you can see that to date the evidence is low quality, but it could be a promising way to address dysbiosis. The figure on the right shows treatment with probiotic and shows that the standard is a person without CF, and you can see how they have a predominance of firmicutes or beneficial bacteria, whereas the person on CF on the left has only 18% firmicutes. Treatment with probiotics helps to normalize this balance. There has been a systematic review of probiotics in people with CF, which included RCTs and non-RCTs of probiotic supplementation. This did show that gut health, gut microbial dysbiosis, and body weight improved after supplementation, but the data could not be pooled as the designs were quite different. There were, however, significant benefits observed irrespective of type of probiotics, and no adverse effects are reported, although this would be something that I would probably discourage if a patient does have a central line. So considering some information from murine models, in a CFTR mouse, the main phenotype is intestinal obstruction and failure to thrive. This gives us a unique model to directly sample the intestinal bacteria and learn from them. The CF mouse models demonstrate the development of SIBO within 4 days of life, with a 40-fold increase in the bacterial load of the small intestine. Normal intestinal transit has been known to be a major factor in controlling bacterial load. And we know that bacteria affects that rate of intestinal transit. So in mouse models, we've seen that animals that are germ-free or colonized only with E. coli have slower transit compared to those who have conventional species flora. In this elegant study from Delisle et al., they treated CFTR null mice with polyethylene glycol as well as N-acetylcysteine, a mucolytic. As you can see in the figure on the right, the treatment with polyethylene glycol was highly effective in reducing the bacterial load, more than 93%. It normalized the intestinal transit time, reduced intestinal mucosa, eradicated bacterial overgrowth, and led to better weight gain. So I join with Dr. Stein in encouraging polyethylene glycol for many of our patients with CF. We also know that food quality is impactful. High-fat diets have been shown to modulate microbiota, resulting in decreased microbial diversity, increasing markers of inflammation. And we do know that variations in diet can impact the microbiota. So I would propose that diet may both contribute to and offer solutions for dysbiosis in people with CF. And this may be important as we think about tube feeding for people with CF as well. There's certainly a need for additional randomized control studies to explore the effect of nutrient balance on health for people with CF. The impact of modulator therapy is something that we're still learning about. Oy et al. Demonstrated that ivacaftor improves intestinal inflammation and evidenced by decreasing fecal calprotectin, with an increase in the relative abundance of Akkermansia, or one of our more beneficial bacteria. Christensen et al. Reported increased gut microbial diversity in people with CF treated with ivacaftor. However, studies of lumacaftor ivacaftor haven't shown a change in microbiota or improvement in SIBO thus far. However, many of these are small studies and have some trends towards significance. There's no studies as of yet regarding the effect of ETI on SIBO. However, additional data from PROMISE will be insightful, as initial data did show some reduction in stool calprotectin. So in conclusion, both SIBO and overall gut dysbiosis are prevalent for people with CF and can have deleterious impacts on health. In large part, SIBO is a clinical diagnosis based on signs and symptoms, and treatment often includes antimicrobial therapy aimed at anaerobic bacteria. Long-term therapy may also include PEG, probiotics, and dietary modifications. And I think it's really important as we move forward to be cognizant of some of the modifiable risk factors that can help prevent this condition. Thank you. Thank you.
And our final speaker of the morning, Dr. Jeffrey King.
Just want to thank Joanne and Jen for inviting me to speak about this very, very important topic today. And I hope to, first off, I wanted to show you that I apparently have one tie in my closet. So apparently I'm wearing for all pictures. So you can recognize me anywhere, just look for the tie. But at the end of all of this, I hope that we can find some common ground as far as terminology when we're describing this both to GI colleagues as well as pulmonary colleagues. I have no disclosures. And so going through the talk, we'll sort of first talk about some anatomy, why this is important with regard to cystic fibrosis. We'll talk about some definitions. We'll review some of the literature about what we know about reflux in cystic fibrosis, and we'll highlight in particular the heterogeneity in the studies and definitions that we've used regarding reflux over the years. Then we'll look at the impact of reflux on the lungs in CF, including those with advanced CF lung disease and lung transplantation. And then we'll really get into the nuts and bolts about how the evaluation and treatment of GERD versus GRASP may be different. So let's talk about the anatomy of everything. My mother is a realtor, so she always enforced that location is important. So as you can see here, the mouth is one tube in the back of the mouth. When it gets to the throat, it breaks off into a fork in the road here, with one branch being the esophagus to carry everything you swallow down into your stomach, the other branch going off through the vocal cords and down into the lungs, the airway. So there's an airway tube and a food tube put right next to each other in your throat. And so when we go through definitions of this, the first thing we talk about is GERD, and a lot of people use this as kind of an umbrella term to include many different things, but here's the definition. It's the symptoms or complications resulting from stomach contents coming up into the esophagus or beyond. There's also a term, LPR, that often gets thrown around, laryngopharyngeal reflux, which is when this reflux comes up and enters into the back of the throat. And aspiration, which is when material either coming from the oropharynx down into the airway or coming up from below from the GI tract and entering the airway. So basically when there's something that's not air getting into the airway. And if for the gastroenterologists in the crowd, we know that our life basically starts at the top of the esophagus and down. And so these sort of top-down phenomenon causing aspiration are generally the purview of speech therapists, ENT physicians, neurologists. And so to differentiate this aspiration coming from below as part of a CF Foundation sponsored workshop a couple of years ago, we coined this term GRASP, or GI-related aspiration, which really informs us about this type of aspiration that's coming from below the upper esophageal sphincter. And the other reason why we wanted to use this term is that not all GRASP is coming from reflux of stomach contents necessarily. There can be abnormalities in motility of the esophagus that contribute to the risk of aspiration. There can be delayed gastric emptying or gastroparesis that can contribute to the risk of aspiration. So not all GRASP is gastroesophageal reflux. So please try to use these terms clinically going forward as much as possible. So why might CF increase the risk of GERD or GRASP? Well, here is a figure which goes through different factors that may increase the risk of GERD and GRASP, and those have up arrows. And there are also factors that can decrease the risk of GERD and GRASP. And in CF in particular, if you go through these, as we heard earlier, CF patients tend to be at a higher risk of gastroparesis. They often have issues with increased abdominal pressure, whether that's from constipation, from diaphragmatic issues. As we'll see, they generally have more gastroesophageal reflux. They have decreased pleural pressures due to pulmonary components of this. They often have dysmotility in the esophagus and can have alterations in the mucociliary barrier of the airway. So there's a lot of factors that tend to put our CF patients at higher risk of both reflux and GRASP. So what do we know about reflux in CF? And as we go through these studies, I want you to pay particular attention to how reflux is defined, and you'll see that I'm not sure I present any two studies where it was defined the same exact way, and that's a real problem with the literature that we have right now. So this is based on a questionnaire out of Minnesota showing that about 2/3 of CF patients had at least one reflux symptom, defined as heartburn, regurgitation, or dysphagia in the questionnaire. That about 1/4 of the patients actually had these symptoms at least weekly. And out of the patients who said that they had reflux symptoms, over 1/4 of those patients felt like there was a correlation with those reflux symptoms and their pulmonary exacerbations or pulmonary symptoms. In addition, we have some objective reflux testing data, which shows the prevalence of increased acid exposure throughout various ages. In adults, up to 90% have abnormal reflux testing. And out of those patients who have abnormal reflux testing, nearly 2/3 may not even have symptoms. And so clinically, if we are simply diagnosing reflux symptomatically or basing who we treat on symptoms, we may be missing the vast majority of our patients here. Now, when you compare the CF, people with CF to non-CF patients, you can see that the incidence of reflux is much, much higher in our CF population. And again, just to reiterate, because this is going to be a theme of the talk, that a lot of these reflux studies have been heterogeneous in methodology, and that there are rare prospective studies that use our current catheter-based pH impedance reflux testing. And actually, none of those even report non-acid reflux, which we'll sort of talk about as we go through the talk, may be very, very important in this population. So what do we know about the effects of reflux on lungs in CF? From radiology studies, we know that patients with reflux seen on esophagram have been shown to have decreased lung function compared to those without reflux. We also know, not just in the CF population, but in lung populations in general, that bile aspiration or bile acids being found in the sputum or in the lungs decreases pulmonary biodiversity through biofilm formation, emergence of a dominant pathogen, and lung damage. And why is this important in CF? Well, we know that CF patients are more likely to have bile acids in their sputum. So when you compare CF patients to healthy controls, patients with other lung diseases such as chronic cough and asthma, you can see that CF patients are more likely to have bile acids in their sputum. We also know that as the bile acids increase, inflammatory markers such as neutrophil elastase increase, and we know that as bile acids increase, FEV1 decreases. Here is a large cross-sectional study out of Europe, which looked at over 7,000 patients, and they tried to identify factors that were associated with low FEV1 at enrollment. And they showed that patients with gastroesophageal reflux tended to be in the cohort that had FEV1 5 to 10% lower than predicted. Now, interestingly about this study is there's a comment in the paper that says that the registry provided no definition of GERD, and consequently, this potential relationship remains to be confirmed. Here is a transplanted patient from Duke University, underwent lung transplant for CF in 1995. And you can see that over several months following transplant, the lung function began to decline. The patient was worked up, and they were found to not have any evidence of rejection or infection. They ultimately were retransplanted approximately 2 years after their initial transplant and had the same dip in lung function. They underwent an endoscopy, which showed severe esophagitis. They had gastric emptying study, which showed delayed emptying. And a barium test, which showed reflux up to the level of the clavicles. And this patient was initially treated with high-dose PPIs and pro-motility agents, again with ongoing decrease in lung function. The patient ultimately underwent anti-reflux surgery with a fundoplication and was then shown to have improved lung function, which persisted. So this suggests that this issue with reflux and taking it one step further, probably GRASP, is a significant contributor, particularly into our patients with the most severe lung conditions, lung disease. Here's a study in lung transplant in CF and non-CF folks, and they studied 43 patients pre and post transplant, and all these patients had GERD. And in this study, GERD, you can see it was defined as greater than or equal to 1 LPR episode, or greater than or equal to 5 proximal reflux episodes, along with endoscopic findings. Or they also threw in PPI dependence. So this is a huge grab bag definition of reflux. So take these data with a grain of salt because of that. But 41 of these patients had anti-reflux surgery, and folks with normal esophageal motility underwent a standard Nissen fundoplication, and those with dysmotility underwent a partial fundoplication. And when you looked at pulmonary outcomes in these patients before and after anti-reflux surgery, you can see that following anti-reflux surgery, nearly all of these lung parameters were statistically significantly better, including lung function, pneumonia, and rejection post-transplant. What we also know is that increased acid exposure and elevated Demeester score on reflux testing, pre-transplant reflux testing, is associated with the development of CLAD and bronchiolitis obliterans syndrome. That we also know that proximal reflux events, and taking it one step further, likely GRASP or aspiration, correlate with inflammation, which is linked to allograft dysfunction and mortality. And the sort of grab bag presence of GERD pre-transplant, you can see here, is associated with decrease in lung function after transplant, as well as decreased survival or increased mortality following transplant. So here's the problem. GERD does not equal GRASP. There is no agreed upon gold standard for diagnosing GRASP. What we do know is that from bronchoalveolar lavage specimens, that there are factors that may be suggestive of aspiration, including bile acids, pepsin, lipid-laden macrophages, inflammatory markers, or even growing bacteria that we think of as GI bacteria out of lung specimens. There are histopathologic factors which may be highly suggestive of GRASP. And there are imaging findings. There are things that you can see on CAT scans with maybe basilar changes or migratory changes on repeated imaging studies. But none of these is diagnostic of GRASP. And what we know from our reflux testing is that the normative parameters that we use to distinguish what's a normal from an abnormal reflux study are all based on esophagus endpoints. This has the normative measurements that we have for our reflux testing actually has nothing to do with whether or not a patient may be more or less likely to be aspirating. And this is very, very important as we interpret the reflux study results and as we structure studies moving forward to decide what reflux parameters may be predictive of GRASP. And that if you take it one step further and you can diagnose reflux, the standard treatments of reflux don't necessarily have any impact on a patient's risk of GRASP. And what do I mean by that? Well, we'll get into that shortly. So where does our reflux testing fall short? So here's the Lyon consensus from 2018. It was actually updated last year, and I mistakenly did not put the new chart in, but there's very little that has changed in the new criteria. And so if you look at this top line, these are the findings both on endoscopy or reflux testing that are evidence or conclusive evidence of pathologic reflux. And that's basically L8 grade C and D esophagitis. Grade B has, in the new criteria, has been added there. Or acid exposure time on catheter or wireless-based testing of greater than 6%. On the bottom, you can see that this is evidence against pathologic reflux. So that's acid exposure time of less than 4% or reflux episodes up to 40 in a 22-hour, 24-hour period. The reason why I want you to, again, these are all based on esophageal outcomes. So what's your risk of having esophagitis, Barrett's esophagus, or cancer? What's your risk of needing to be on a PPI? What's your risk of having esophageal symptoms? None of these parameters has anything to do with whether or not your reflux may be impacting your lung disease. And so even in these patients here who may have 35 reflux events in a 24-hour period, that doesn't mean that they're not aspirating. That may mean that they're at a decreased risk of having Barrett's esophagus or heartburn, but it doesn't mean that they don't have grasp. So interpreting these data in the context of your individual patient is very, very important. I have a patient I always talk about that I saw come to us who said, I've been coughing for a while and I have these lung issues, and my local doctors thought about reflux and they did formal reflux testing on me, but I don't have a reflux problem. And I say, well, show me your reflux test. And what they showed me was pH impedance testing showing that they had 35 reflux events during the day, so that's considered normal. 22 of them reached the upper esophagus. And when you put that in combination with their lung cultures growing E. coli, their CT scan showing basilar migratory changes in the lungs, that it sort of walked like a duck and quacked like a duck, that this was likely an issue with grasp. And if you go simply based on the reflux test interpretation, which was normal, you're going to miss that in your patients. In the 2018 consensus, they made a couple comments that are relevant to the grasp conversation, which is that the clinical relevance of an abnormal number of reflux episodes remains incompletely defined, and that assessment of proximal esophageal or pharyngeal reflux has been proposed, but the methodology and interpretation have not been standardized, and outcome studies are lacking. So basically, we have no idea how to utilize our reflux testing results as it may relate to grasp. So where does our reflux treatment fall short? Well, what we know from the CFF patient registry is that a lot of CF patients are on acid-suppressing medications. Upwards of 50% of adults either on a PPI or an H2 blocker. We also know that PPIs actually do nothing to reduce the number of reflux episodes. So this is reflux testing on and off of PPI. And what you can see is that reflux episodes are the same, whether or not you're on a PPI. The next slide that I'm going to bring up, there's three times in my life where I remembered exactly where I was when something happened. It was the Challenger disaster, it was 9/11, and it was when I saw this next slide, okay? So I hope this is as meaningful to you as it was to me. So this is a study that looked at reflux testing on no anti-reflux medications. They put patients on twice daily, so high-dose PPI omeprazole for a week, and they repeated reflux testing. And what you can see here is that the PPI virtually got rid of the patient's acid reflux. But if you look at the total number of reflux episodes, it is unchanged. So what happens? Well, what happens is by reducing the acidity in the stomach, you basically make everybody's reflux go from acid reflux to non-acid reflux. With regard to the esophagus, that's a really good thing. You're going to decrease heartburn, indigestion, Barrett's esophagus, esophagitis. But with regard to grasp, if we haven't done anything to reduce the number of reflux events a patient has, we've probably made no impact on their risk of aspiration and no impact on their risk of having lung complications of their reflux. And I'll take it one step further. Is putting patients on an acid reducer potentially detrimental to our CF patients? Here's a randomized control of adult CF patients without GERD, so asymptomatic adult CF patients. The inclusion criteria is that these were patients who had frequent exacerbations requiring antibiotics over the previous 2 years. They were given reflux testing, and then they were randomized to high-dose PPI or placebo, and they were followed for 36 weeks. 60% of these patients, again, without symptoms, actually had abnormal reflux testing, and here you'll see definitions, what they used in this study of abnormalities, which are very different than current consensus recommendations. And that about half of the patients, or more than half, excuse me, on the esomeprazole arm had an exacerbation, where only a quarter in the placebo had an exacerbation. And so the odds ratio of pulmonary exacerbation or time to first exacerbation was higher in the esomeprazole group. Here's another study, a retrospective study, which looked at whether or not PPI was associated with higher hospitalizations or pulmonary exacerbations. And they identified 114 adult patients who had been on PPIs for 6 months prior to the year that they looked at for the study. And a majority of those patients were on once daily PPI. And in this study, again, the history of GERD was simply based on symptoms, not in any objective testing. But what they did find is that those who had been on PPI had a higher risk of hospitalization for pulmonary exacerbations. And why is this? Well, we just got done talking about how these medications actually don't reduce reflux. And in addition, by reducing the acidity in the stomach, we may be providing an environment where bacteria that we ingest throughout the day is not killed off as quickly by that highly acidic environment. And so those bacteria may linger in the stomach for longer than they should. And if that patient is having reflux, now it may be bringing with it more bacteria than it previously had. So where does our reflux treatment fall short? So this is a graph looking at many different factors that all wind up with aspiration, okay? And this is really what we're trying to treat in these patients with GRASP. We're trying to decrease the chances that their reflux or other factors are going to get into the lungs and cause lung issues. Unfortunately, basically what we treat right now is this. Out of all these factors, this is what we treat. We treat acid in the stomach. Where we really should be paying attention is what can we do to decrease the chances that reflux will come up high in the esophagus, close to the airway. And through that, there may be other areas where we should be focusing our attention, such as improving gastric emptying, such as fixing a hiatal hernia if present, such as improving esophageal clearance, decreasing relaxations of the lower esophageal sphincter. And how do we do that? There are some proposed ways to do that. There are a barrier method with alginate to try to prevent reflux from happening, baclofen and bethanechol. I use them quite frequently off-label to help improve esophageal motility, decrease transient relaxations of the lower esophageal sphincter. There are pro-motility agents, lifestyle changes, and anti-reflux surgery, which all work very, very differently than acid reducers. All right, so if you take something away from this, always in clinic, always apply the fortune cookie rule. So what does this mean? We all know what this means. When you were sitting around after your Chinese food and you read your fortune cookie, what are you supposed to do after you read your fortune cookie, right? You say, in bed. I Googled this to make sure I wasn't a freak, that like my parents were the only ones that used to do this. I Googled this as a thing. This is what you say, and everybody sits around and laughs, right? So what I want you all to do in clinic is when you're taking care of these reflux patients and you're reviewing their reflux testing or their treatment response, I want you to insert as it relates to the esophagus after that. So when examples are, my CF patient's reflux testing was normal as it relates to the esophagus, not the lungs. PPIs are controlling my patient's reflux as it relates to the esophagus. Again, this may have no impact on how it relates to the lungs. So where do we go from here? First off, I think we're thinking about this backward. We're looking at reflux testing or reflux symptoms, and we're trying to predict based on that who is aspirating or whose reflux is impacting their lungs. I think we need to flip it on its head. I think first, we need to determine a gold standard for diagnosing GRASP. And once we have that gold standard, then we need to work backward. What surrogate markers can we use to predict risk of GRASP? Is that a barium study? Is it reflux catheter-based testing or wireless testing? Is it motility testing of the upper GI tract? And then once we have that, we have to determine what clinical interventions may reduce the risk of GRASP. And then taking it one step further, only then are we able to come up with recommendations of what to use clinically to evaluate and treat GRASP. So the take-home points are that GERD is highly prevalent in the CF community, and that GRASP can contribute to lung dysfunction, infection risk, and advanced lung disease. We know this. But GERD does not equal GRASP, and you should think about them independently. And because of that, when you evaluate one of these patients, you need to really think about, am I evaluating GERD, in which case there are clear recommendations about how to do that, or am I evaluating GRASP, where there are not clear recommendations about how to do that, and I hope we move in the direction where we have some of those. So just to finish up, I want to thank the CF Foundation for their funding, both through Digest and Leadership and Design grants, that my collaborators on a lot of this work, Christopher Velez, Isabel Nuringer, and mentorship from Sarah Jane and Steve, as well as our adult CF program at National Jewish. Thank you.
Thank you, everyone. Wonderful talks we've had today. So we do have some questions that came in on the app, some of them similar, so we'll try and bring some of those together. One of them having to do with the use of PEG, and in the event of constipation and or DOS, how do you then taper? How do you taper the dosing of PEG after the patients have?
Let's see, these are on.
Maybe we'll do this. How do I taper PEG or mirror?
After constipation or DOS.
Got it. So one thing I want to emphasize is there's no real way to, no real guideline on how to prevent DOS, but treating underlying constipation is one good way of approaching it. So when we treat constipation, I tell people it's an indefinite treatment, but we can modify based on how people feel. And we tend to titrate pretty aggressively up or down. So if you start a patient on PEG, it's a moving target, and it's important you talk to people about this. And you can flex up, you can flex down. Some days will be better, some days will be worse. So it's a very individualized taper. It depends on how proactive you want to be. But there's no right or necessarily wrong way of approaching it. It's more trying to individualize how people feel with PEG. It's a hard question to answer in aggregate. I guess the best answer is it's an individualized approach.
Okay. And still along the lines with PEG is patients who are resistant to utilizing bowel care regularly or have a GI doctor who do not want patient to become dependent on laxatives, including PEG, can you discuss if dependence is unavoidable or if that is even a concern with CF?
Yeah, that's always a historical thing. We don't want people to be dependent on these medications. I question what that means, dependence. I think people are not dependent on laxative necessarily. It's more the constipation is prevalent and they need something, whether it's PEG or something else, to prevent getting that constipation feeling. So it's not necessarily a dependence, it's rather a need. It's sort of like people who have high blood pressure. You can do things to improve high blood pressure that are lifestyle things, exercise, lose weight, salt intake, things like that. There are ways to mitigate constipation as well, again, staying hydrated, other things, but ultimately, people have high blood pressure, people have constipation, and we need to use medications both to get people better as well as to keep people better. It's not necessarily a dependence.
Yeah, that's a good question that I don't necessarily know off the top of my head. My understanding is that a lot of the effects of the GLP-1 agonists are really through delayed gastric emptying in addition to a number of other things, but I'm unaware of its effect on the lower esophageal sphincter. And so that's where, again, if we're talking about GRASP, that's not just necessarily a lower esophageal sphincter reflux issue. It may be, in that case, more of a delayed gastric emptying issue than it is so-called standard reflux mechanisms.
And I think, Dr. Gable, you may be able to help with this one. How do you approach treatment with PEG as first-line treatment when some parents are so against it, believing it causes adverse effects?
Well, that's something that certainly takes a lot of time in discussing with families. So I think it does involve talking about the safety record of Miralax or PEG in patients. Similar to Dr. Stein, I often share that, I've used it in my own children. I do think that helps people feel comfortable. I do think there are some data showing that people with CF may benefit from having 2 to 3 bowel movements a day. Thinking of a low dose of PEG to help facilitate that and certainly help with intestinal transit and bacterial overgrowth can certainly be useful.
Thank you.
Thank you. This one is for GRASP. Would you suggest GJ tube oh, good, it disappeared on me. GJ tube insertion for feeding? Any benefits of swallow therapy?
Yeah, so the main issue with GRASP is it's kind of, as I presented, it's kind of the wild, wild west, where we sort of don't really know exactly what interventions work best in reducing a patient's risk. But you can imagine that post-pyloric feeding with a GJ tube may be or is likely to be more beneficial than feeding into the stomach. The farther away from the lungs you can get contents, the better in general, but there's zero data on whether or not that is beneficial in GRASP.
Thank you. Next question is on gastroparesis. Medicinal management for pediatric patients. Is there a reason that erythromycin is more commonly prescribed as opposed to the metoclopramide for patients older than 12 weeks?
Yes, erythromycin has been around for so long that I think everybody's comfort level is different. When we talk about metoclopramide, the first thing everybody thinks of is neurological side effects and tardive dyskinesias that are irreversible. And I think that is why our first line go-to in pediatrics is we go for something that is least harmful to the patient. We try erythromycin. If that doesn't work and they have severe symptoms, then we go to regular metoclopramide.
I don't know if we're going to throw this one to you, but the most upvoted question was, some of my female adult patients are reluctant to undergo anal manometry due to previous abuse. Any suggestions for alternative testing to rule out a pelvic floor disorder?
You can tell by my silence that there's really not a good test, but oftentimes if people are reluctant to undergo anal rectum manometry, we can go straight to physical therapy. So let me back up. I didn't get into this too much in my talk, but oftentimes what can happen is the muscles of the pelvis just don't allow stool to pass, and it's not a squeeze issue in terms of transit through the colon. It's more of an outlet issue. You can't get things out of your bottom. And physical therapy by somebody who actually knows what they're doing, and this is where choosing a provider is very important. Choosing a physical therapist that can really help with the pelvic floor is very important. Not all physical therapists can do pelvic floor physical therapy, but instead of doing anorectal manometry, which is the gold standard of how you look at pelvic floor dysfunction or those muscles in that area, you can have a physical therapist evaluate your patient and then see if physical therapy would be appropriate. So sort of skip that step.
Thank you. Next question is, can you explain why a low-calorie diet is recommended for patients with gastroparesis?
So it's based on the normal emptying, the normal physiology of gastric emptying. So low-calorie foods have a faster gastric emptying compared to high-calorie foods, which means it also depends on the proportion of fat in your food. So based on the dietary content, so if we are looking for foods that are rich in carbs, that's going to not give us as many calories. So if you're looking for high-calorie foods, they're mostly rich in fats. And fat-containing foods are going to have delayed gastric emptying. That is the reason why low-calorie diets are recommended or low-fat diets are recommended for gastric emptying, for gastroparesis.
Thank you.
Thank you. In young children with constipation managed at home, how many days should PEG be given? Are some patients advised to take daily PEG forever? And if yes, why? I think you kind of covered that.
I don't know if you all want to take this because I'm not a pediatrician, but yes, PEG can be used forever. It's not something that we tend to worry about, with the asterisk that we're always evaluating both safety and efficacy of medications, but it's certainly something that if it works, you can continue it indefinitely. In terms of, I think the other part of the question was how often to use it.
If you're going to use it every day, is it forever? Is that okay?
Yeah, I would think so. But again, trying to keep in mind what is the underlying etiology of the constipation. With kids, I know behavior is definitely something that comes into play. Adults somewhat as well. We call them bowel habits for a reason. Bowel habits, it's a habitual thing. Everybody has their favorite bathroom that they like to use, things like that. And when we travel, we all get out of our habits. So behavior is something to really pay attention to in children and adults to a certain extent. But you can use Miralax every day indefinitely.
Thank you. In response to gastrographic enema dependence on concentration, I think, do any of the speakers have recommendations?
The concentration? Well, let me say, and I feel terrible, I neglected to say this in my talk, and I wanted to. When you use contrast to treat DOs, do not use barium, okay? I should have emphasized that. I should have had a big thing on my slide that said no barium, and I regret that, because what happens with barium is it can basically turn stool into concrete. So if you have a person who you're treating with constipation or other things, and you do a CT scan with barium, be prepared to have problems with constipation afterwards. Or if you're prone to DOs and you give barium, that can potentially trigger it. Now, on the other hand, water-soluble contrast, such as what the person is referencing, gastrographin, it does not turn into concrete. It's actually soluble. It can easily pass, mix in with stool, things like that. In terms of diluting, it really depends on your radiologist in terms of how they would do the actual test. Depends on the product as well. I'm trying to think off the top of my head if I know a dilution factor. I don't know if you...
And it is hard. I think some cases the radiologist may not be familiar with doing this and may not be comfortable. A reference I use used is Zahara et al. I think it's probably got to be 20 years old, but it does go into the nitty gritty, and sometimes that's really helpful.
Yeah.
Just to comment that on gastrointestinal illnesses, we had a lot of pushback from our radiologists because when they did gastrointestinal illnesses, patients and there's abnormalities, especially in the gastric patients. So we at our center had a lot of pushback from our radiologists refusing to do a gastric enema. But if we more animals between the water soluble contrast enema to help, so there's a difference. I think the ionic concentration for all gastric versus really water soluble enemas.
pH impedance studies, wouldn't the Journal of Symptoms during study help recognize grasp despite the score of GERD?
So this just gets back to how we do reflux testing. One of the parts of reflux testing includes pressing buttons on the recording box when a patient has symptoms, whether those are GI or pulmonary symptoms. And so you can, so that's probably the least reliable part, or it is the least reliable part of the testing, because it depends on your patients remembering to press the button when they have a symptom, right when they have the symptom. And again, not all symptoms, even if they're lung symptoms, are aspiration events, right? So that's where I think if we work backward and first try to really determine how can we tell if a patient is aspirating, and then go back at the current testing that we have available and what's predictive of aspiration, there may be a component of that that's symptom-based. But that is in general the least reliable, and on one of the slides where I go through the interpretation of reflux testing, the symptom correlation is sort of an adjunctive measure to help with diagnosing reflux, but it's not one of the standard criteria.
Thank you. And actually, no, this one will probably go to Dr. Stein. Can a physiotherapist help to reduce gastro reflux associated with cougar?
With what?
Cougar.
Cougar?
Caroline, are you still here?
Colleagues? I'm sorry, I'm not familiar with that term.
Well, we're hoping you knew.
Maybe they'll clarify in the app.
I have a question of my own for you guys. I noticed when they first regulated pancreatic enzymes 10 plus years ago, whatever, when they finally did that, we saw a great decrease in incidence of DOs in our particular clinic. Does anybody else find that to be true, or are you still? I don't. But my new radiologist doesn't even know who I am because I haven't ordered an enema in so long. Have you noticed the same?
Yes.
And I think that takes care of the majority of our questions here, because we tried to group them. And it's now 12:15, so everyone safe travels home and enjoy the rest of your day.
Thank you all so much.